Good afternoon, everyone. It's a great honor for me to be here in this beautiful city of Rome. First, I'd like to thank the AllSTEM Organized Committee for inviting me here to this meeting. Today, you might have a lot of information about advanced dental implant surgery, including sinus surgery, ridge augmentation, the ridge splitting. But now, I would like to share with all of you about something very basic about the concept of implant placement for long-term mechanical and biological stability. First, we would have to know what is the implant success criteria. The implant should have no pain, no mobility, no marginal bone loss, and not damage the natural tooth, and not violate the vital structures such as the maxillosinus and especially the inferior alveolar nerve. Moreover, the implant restoration should have an acceptable aesthetic result for the patient. In order to provide all these success criteria, the implant must be placed in a proper position, the treatment success should be predictable, and moreover, it should be easy and practical for all practitioners. The 3D implant positioning concept, we provide a proper implant position. The three compositions of the 3D implant position are: first, the mesial-distal implant position and angulation; second, the buccolingual implant position and angulation; and last is the apicocolonal position, which is the installation depth of the implant. With all three implant positions, the implant restoration will achieve an aesthetic and long-term functional stability. The first rule for mesial-distal implant position is that the implant must be placed in the center of the restorative crown. This position is the midpoint between mesial and distal surface of the restorative crown. The correct mesial-distal implant position, when the implant supports the occlusal frost, the frost will go along the long axis of the implant, and this position will provide a long-term biomechanical support for the implant. Having a good biomechanic means the chance of prosthetic complication will be less, including screw loosening or screw fracture, or sometimes even an implant fracture. Even AllSTEM provides us the ESR and EFR kits, but we don't want to use that, right? From the radiograph, you can see that this implant is a very big implant, about 6 millimeters in diameter, and was placed only about 2 years ago. The patient comes with a loose prosthesis, and the periapical radiograph show that there's some foreign body between the implant and the abutment connection level. There were marginal bone loss on the mesial side of both implants. First, I thought this is an excess cement, but when I removed the crown and abutment, I was surprised to see that both implants are fractured at the collar level. If we look at the mesial-distal implant position again, you can see that this implant is placed too far distally and is off axis of the occlusal loading, causing biomechanical failure. Rule number 2 for the implant placement in Rule number 2 for the mesial-distal implant position is that the implant should be placed about at least 1.5 millimeter away from the natural tooth. And if the implant is placed too close to the natural tooth, the lack of blood supply will lead to alveolar bone resorption, and we might lose both natural tooth and the implant in the area. Now we understand about mesial-distal implant position. Next is the angulation of the implant. From the panoramic radiograph and the reconstruction image of the cone beam CT, you can see that most of the teeth is tilted in the mesial side, except for the mandibular incisor, which is quite straight. So when we install the implant, the mesial-distal implant angulation of the implant should follow the mesial tilt of the natural tooth too. to distally angulated angulation is most common error and is an iotrotic trauma, and it is an unacceptable complication in implant dentistry since we inform our patient as the treatment option that not harm the adjacent tooth like the dental bridge or the removable denture does. This is the hands-on model picture from basic course training. These two implants was placed in a correct mesial-distal and buccolingual position. Also, the parallelism of these two implants are just perfect. Actually, if we look at the mesial-distal implant angulation, the natural tooth, this implant might contact the tip of the natural tooth already. So please keep in mind that the implant angulation should be placed along the long axis of the natural tooth too. Now, we understand about the mesial-distal implant position and angulation. Next dimension that we have to consider is the buccolingual implant position and angulation. There were also two rules for the buccolingual implant position. First, the implant should be placed in the center of the restorative crown. And this position can be found easily from the midline between the buccal and lingual surface of the adjacent tooth. And the cross-section of this mesial-distal and buccolingual going to be the best position for the horizontal position of the implant. The cross-section of the buccolingual and mesial-distal going to be the point where we're going to place the implant. This implant was placed from another dental practice. The patient come in and asked me to complete the final restoration after 3 months of the implant placement. The X-ray showed a good implant position, but after the flap elevation for the second stage surgery, I found that the implant thread is exposed on the buccal side. From the occlusal view, we can see that the position of the implant is placed too far toward the buccal side. If this were your patient, do you feel comfortable to put the implant in this, to put the crown on this implant? Do you? No, right? Because if we place the crown on that implant, we might face the problem of the prosthetic complication. Rule number 2 for the buccolingual implant position is that the implant should have at least 2 millimeters of buccal bone. This bone structure will help support the implant and will provide a good blood supply for the gingival epithelium. If the implant is placed outside of the buccal safety zone and the bone is too thin, we know that the complication including the loss of the buccal bone and the gingival recession will likely to happen. So, what do we do when we do not have enough bone thickness? It is common to have the buccal bone loss on the implant. So, should we place the implant in this position? Because we have 2 millimeters of buccal bone rule. But rule number 1 should be respect to, should not be violate the rule number 1, as the implant should be placed in the center of restorative crown. So, implant should place in that position correctly. But if the bone is not enough, we have several options for the bone management, including the ridge augmentation, and in this case, I choose the guided bone regeneration technique to augment the bone, to have 2 millimeters of the buccal bone rule. Or we could do the alveoloplasty or the ridge expansion. Alveoloplasty can be done sometimes when the bone height is enough and the alveolar bone base is wide. The alveoloplasty might be the good option for this case. The downside of this technique is that the loss of cortical bone, the implant primary stability will be less and it's more difficult to achieve the primary stability. And the crown to implant ratio will be increased. So compensating this ratio, sometimes we have to place the implant deeper into the bone and have more risk of the nerve damage or the sinus perforation. Another technique, in case that we have not enough buccolingual bone is that we do the ridge expansion or ridge splitting. But this procedure is quite the technique sensitive procedure. So high operator skill required for this technique too. Now we know the position of the implant in buccolingual. What about angulation? If you look at the sagittal view from the cone beam CT, you can see that teeth are not straight or perpendicular to the ground floor. The mandibular teeth is tilted lingually, and the maxillary teeth is tilted buccally. So when we drill or when we insert the implant, we should drill, face the drill toward the functional cusp side. In the maxillar, we drill toward the parietal root, and in the mandible, we drill toward the buccal cusp of the molar area. If we place the implant perpendicular to the marginal bone level, on the mandible, we're likely to perforate the lingual concavity of the mandible, and this complication, we have sublingual hematoma, and the tongue of the patient will be elevated and block the airway. And if we not treat it in time, patient could die from this condition. To correct the buccolingual implant position, the patient will ask to close their mouth after the initial drill. With the guide pin in place, the pin should face toward the central fossa of the opposing tooth or the functional cusp of the opposing tooth. Once again, when the implant is installed, we should be confirmed that this buccolingual angulation is correct by asking the patient to close their mouth. Tip of the pin should face toward the opposing functional cusp, and this biting force will go along the long axis of the implant. This is very important. The first clinical case today about the implant position is that my patient come in and asked to have the smile makeover for her front teeth, and she asked to have the fixed implant restoration for her missing posterior teeth with dental implant. And she also requests to have the immediate fixed temporization on her implant. But from the picture, you can see that the alveolar bone may not enough. There's some bone resorption in that area. Let's see if this case is possible for the immediate temporization or not. May I have some sound, please?
I ain't worried about nothing. I am wearing a nada. I'm sitting pretty impatient, but I know you gotta put in them hours. I'ma make it harder. I'm sending pic after picture. I'ma get you fired. I know you're always on that night shift, but I can't stand these nights alone. And I don't need no explanation, 'cause baby, you're the boss at home. You don't gotta go to work, 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 but you gotta put in work, 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 work. You don't gotta go to work, 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 work. Let my body do the work, 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 work. We can work tomorrow. Oh, oh. We can work tomorrow. Oh, oh. Let's put it in motion. I'ma give you a promotion. I'll make it feel like a vacate. Turn the bed into an ocean. We don't need nobody, I just need your body. Nothing but sheets in between us, ain't no getting off early. I know you're always on that night shift, but I can't stand these nights alone. And I don't need no explanation, 'cause baby, you're the boss at home. You don't gotta go to work, 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 but you gotta put in work, 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 work. You don't gotta go to work, 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 work. Let my body do the work, 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 work. We can work tomorrow. Oh, oh. We can work tomorrow. Oh, oh.
Oh yeah, girl gotta work. clap no hands for me. Take it to the ground, pick it up for me. Look back at it all, I'm for me. Put in work like my time, she ride it like a 63. I'ma buy a new Celine, let her ride in the forest with me. Oh, she the babe, I'm her boo, and she down to break the rules. Ride it down, she gon' go, I'm gon' choose. She finesse, I fight up, she take that. Putting overtime on your body.
You ain't gotta go to work, no. Work, but you gotta be work. You don't gotta go to work, and my body do work. Do work, yeah, we can work from home. We gon'
Okay, now we understand about the mesial-distal and buccolingual implant position more, right? The last dimension going to be the vertical dimension or the apical-coronal position of the implant. This is always the part that most confusing in implant practitioner. Because in general we know that the implant should be placed about 3 to 4 millimeter apical to the expected gingival margin of the final restoration, as the vertical aspect play a very important role for the implant biologic width. What is the biologic width? Biologic width is the soft tissue thickness that protects the inside from the outside invasion. The outside means in oral cavity we have those foreign body bacteria try to invade into our bone level. So from the classic paper in 1961, very old paper from Dr. Gallego from Italy, the mean biologic width is about 2.04 millimeter, which 1.07 is occupied by the connective tissue attachment, and another approximately 0.97 is occupied by the junctional epithelium. In general, most of the soft tissue measure from gingival margin to the crestal bone level is about 3 millimeter. When we place the bone level implant, have you ever had a question in mind that how deep are we going to place the implant below the crestal level? It's always a question, right? Somebody say that 1 millimeter or 2 millimeters subcrestally. What is the exact number? It's still mysterious. In general, as the natural tooth have a dental-gingival junction, the same term can be used for implant. The implant have the implanto-gingival junction, and these have a similar histological structure to the natural tooth. So we would require minimum of 3 millimeter of this healthy soft tissue when we place the implant. So the implant should place at least about 3 millimeter from the gingival margin to provide a good biologic width. But since the orientation of the connective tissue fiber around the implant does not have the perpendicular fiber as in the natural tooth do, so it is the epithelium around the implant is more prone to be invaded by the foreign substance and the bacteria than around the natural tooth. The deeper implant installation from 4 to 5 millimeter is more recommended. In the TS implant system, we have the part that we call the healing abutment, which we have 3 different healing abutment height that we can use, 3, 5, or 7 millimeter. And as demonstrated by Dr. Cho, he liked to use 5 millimeter of healing abutment in his life surgery. This is because he can easily do the depth control by using the 5 millimeter healing abutment. The first implant, you can see that part of the healing abutment is exposed only 3 millimeter. That means the installation depth is only about 2 millimeter, and it's not enough for the biologic width. The second implant was placed about 3 millimeter from the gingival margin, and we have about 2 millimeter of the healing abutment exposed over the oral cavity, and that's acceptable in terms of biologic width. And it will be even better if we have the installation depth about 4 to 5 millimeter. What happens when we have the shallow placed implant? This implant is placed about 1 to 2 millimeter below the gingival margin. Can you guess where the marginal bone level will be? As you know from the biologic width, the bone will set back for the natural protection, and it would lead to crestal bone loss below the fixture platform level. The radiographic show that these two implants have bone loss around the marginal bone level. So, if we place the implant deeper, about 3 to 4 millimeter from the gingival margin, there also be some bone remodeling around this implant. There will be some bone socialization, and the bone will that's remodeling will not decrease below the platform level because it has already enough biological width. So the bone will be well maintained around the implant body, and this will give the implant strength. But from patient to patient, we have different gingival thickness. Some would have a thick gingiva, some would have a thin biotype gingiva, and from the same person, different side, like in maxilla, we usually have thick gingiva, and in mandible we have thin gingiva. So we can apply this standard. We actually doesn't concern about how deep are we going to place the implant below the crestal level. We concern that how deep are we going to place the implant below the gingival level. So in thick gingival case, sometimes we can place the implant at the crestal level. As long as we have 3 millimeter of biologic width, and most of the time in the thin gingiva, we have to place the implant deeper into the bone because this bone going to resorb and form the biologic width like that. So the biologic width is the amount of soft tissue and the hard tissue together. The benefit of deeply placed implant is that it will prevent the bone resorption, as you can see from the previous slide. When we place the implant too shallow, there will be some marginal bone loss, and it will reduce the potential of having peri-implantitis. And when the implant is placed deep enough, we will have a good emergence profile. When the implant is placed shallow, like this, the implant crown actually looks shorter than the natural tooth, meaning the implant doesn't have a good emergence profile. And the last one, the important part, is that the implant will have good yield strength. What is the yield strength of the implant? From the finite analysis, the dental implant showing that if the implant is having the marginal bone support around it, the yield strength is good. But when we have 2 millimeter of marginal bone loss, the same size of the implant have lost its strength a lot. So it's important to have the marginal bone support around the implant body. This will provide a good long-term stability. Like this implant, it's a bone recession. After some cyclic loading from the occlusal force, the implant itself is even fractured and has to be removed. So we don't want to have this problem for our implant, right? The Ostem fixture driver with the laser marker is a very useful tool for adjusting the implant depth in case we do implant depth control. Each level of the laser marker is about 1 millimeter apart. This is important to make sure that this fixture driver is connected to the implant completely before turning the instrument, because if the implant fixture driver is not connected completely, we could cause severe damage to the internal connection of the implant. This case, we have the flapless immediate implant placement on tooth number 21. And once the implant insert, we remove the fixture mount, and the fixture driver has been connected. And at the installation depth, you can see from the laser marker that installation depth is 0 millimeter. And once we turn the instrument clockwise, we can deeper installation to the desired depth, which is about 3 to 5 millimeter of installation depth without the flap opening, because we know that if we raise the flap, we might lose the gingival architecture or the gum recession from the flap opening. The second case today, we have the case tooth number 15 need to be removed. You can see the tip of the root is at the floor of the maxillary sinus already. Another alternative option would be the crown lengthening to provide a good furrow effect and then do the post and crown. But the gingival level will be different from the tooth next to it. And after discuss with the patient decide to do the dental implant. The cone beam CT scan showing that tip of the root is already at the floor of the maxillary sinus. Is this good for the immediate implant placement? No, right? The best method going to be remove the tooth, wait for the socket healing. Once we have a good bone, we could achieve the primary stability easily. So, but if that's the case, it's going to be too simple. For Ostem World meeting, we have to do something more advanced. So I extract the tooth carefully, and then we place the Ostem TS3CA implant, and then we insert the implant, engage the proximal bone to get the primary stability. Because we don't have the apical bone, because it's at the sinus 4 level already, right? And then we leave the 2 millimeter of the labial bone to follow the rule as the mesial-distal implant position, center of restorative crown, 1.5 millimeter away from the natural tooth, buccolingual implant position. In the center, you can see it, the core screw hex is along the central groove of the adjacent tooth, and 2 millimeter of buccal bone will be grafted. And installation depth, with the using of 5 millimeter of healing abutment, 2, 1, or 0 healing abutment exposure means we have 3 or 5 millimeter of installation depth of this implant. Then we're going to wait for the osseointegration about 3 months. Then the healing abutment will be removed. You can see that the good soft tissue profile around this implant will be a good biologic width to protect the bacterial invasion in the future. So now we connect the abutment, final impression, and make the final restoration for the patient. With a good installation depth, the marginal bone will be well maintained around the implant body. And this will have a good long-term mechanical stability. The next case is from Dr. Tira. He is one of my students in Ostem AIC basic course training in Thailand. He presents the case with 2 missing teeth. He has doubt about where going to be the apical coronal position of the implant. We have 2 options. Option 1, we place the implant by the surgical driven method, and the second is replaced by the prosthetic driven method or the top-down implant planning. This is a picture of 3 different bone levels. With the surgical driven implant installation, we have learned that we have to place the implant about 3 millimeter away from the gingival margin to provide a good biologic width. The result from the surgical driven method is that we might have the crown that is too long, too short, or actually we don't know that the implant is in a good apical coronal position for our restoration or not. So, coming with the prosthetic driven, the shape of the final restoration will be considered as a priority. And we do not measure the implant position from the bone level. Either the bone is too far from the cervical margin or too close to the cervical margin. We do just concern that we have to place the implant exactly 3 millimeter from the cervical margin of the restoration. In this case, the bone is not enough. Picture on the right, the bone is not enough for the implant, then the bone augmentation should be applied. And if the bone is too much, then there could be some bone reduction to have a good biologic width. Back to the case, Dr. Tira has planned for the prosthetic-driven standpoint. So starting from the full contour of the final restoration, he turned this wax to the clear surgical stent and sent the patient to do the CT scan. The radiographic stent can be also used as a surgical stent to correct the mesial-distal and buccolingual implant position. And now for the implant depth control. Looking from the CT scan, he knows already that the bone is too much in this case, and he needs the bone reduction. So how do we transfer this information into the oral cavity? How much bone reduction do we need? So after the fixture mount has been removed, the surgical stent will be reinserted, and the round carbide burr will be used to create the artificial bone saucerization and form the emergence profile of the implant restoration. Get it? Okay. The next case is a summary of everything. We can do the prosthetic-driven implant planning and understanding about the concept of having 3D implant positioning into this case. This case, he have irregular or symmetry smile, and we like to create the smile for him in a green line. And intraoral picture, you can see that the occlusal plane is irregular. Contact point is already on the canine on both sides. He have not enough restorative space on the posterior region. Let's see what happened in this case.
Welcome to the feature remix. Major Laser.
Do you recall, not long ago, we would walk on the sidewalk? Innocent, remember, all we did was care for each other. But the night was warm, we were bold and young. All around, the wind blows, we would only hold on to let go. Bucket, fire gun, we need someone to lean on. Bucket, fire gun, all we need is somebody to lean on. Bucket, fire gun, we need someone to lean on. Bucket, fire gun, all we need is somebody to lean on.
Man, yo sé lo que te enciende. Te hablan de mí y ahí mismo te prendes. Pasas de ser fría a caliente. Nos vemos en mi casa muy frecuentemente. Dispárame un beso, mátame lentamente. Vive el día de hoy, pásame tu energía. Dos almas libres en sintonía. Ni yo soy tuyo, ni tú eres mía. Si tú te fueras, ¿qué falta me haría? Let's go. Sabes que eres tú, en la que confío como tú ninguna. Somos iguales y de eso no hay duda. No eres mi novia, tampoco mi amiga, pero me alegro, es completa la vida. Y ella me dice que muy bien me entiende, que no es fácil manejar tanta gente. Quiero que se vean conmigo y que el mundo sepa que yo en ti confío. Miremos alrededor, el tiempo pasa y la brisa escapará a nuestro favor. No tenemos que complicar, por si tú y yo sabemos lo que después de aquí pasará. Sube, prende el botón en on, y quien repite esta canción, la perfecta para la ocasión. All we need is somebody to lean on. Sube, prende el botón en on, y quien repite esta canción, la perfecta para la ocasión. All we need is somebody to lean on.
Bucket, fire gun, we need someone
So if we place the implant in a correct 3D position, we would have the long-term stability, right? Now the conclusion today, the mesial-distal implant position should be the center of the restorative crown, and it should be away from the natural tooth at least 1.5 millimeter. The angulation of it should be a little bit mesial tilt or follow the natural tooth. The buccolingual implant position, again, it has to be in the center of the restorative crown, and it should always have 2 millimeter of the buccal bone for the structural support. And the angulation should face toward the opposing tooth functional cusp. And the last, the vertical aspect, that we should place the implant about 3 to 5 millimeter from the cervical margin of the final restoration. Understanding the 3D implant positioning, that we have the long-term implant success, and studying and learning about this technique, we make our surgical implant simple and practical. And the technique could be predictable and repeatedly of success if we do it more and more. This is not the only technique as presented from the previous live surgery. The computer-guided surgery, I have no doubt that the implant will be placed in a proper position. The result will be the most predictable, but it might not practical for all practitioners, since there could be more instrument, more cost to prepare the surgical stent, more time consuming in the treatment planning step. Okay, here's the last. Sound.
Okay, this time is late.
Okay, done. Last.
Emma.
Every day it's getting on my nerves.
Emma.
This is
Emma.
Okay, thank you.